Studies have shown that hospice provides comprehensive care and can improve the quality of life for patients at the end of their life. Yet, in the national average length of service for patients on hospice is 18.5 days, according to the National Hospice and Palliative Care Organization, which is a really short period of time. Patients aren't enrolling in hospice until literally the last days of life, and usually very late in the course of their illness. So why is that? Why are we seeing that? So we researched some barriers, and these are what we found. And the first one we found is that hospice eligibility requirements can be a really big barrier. A patient's medical condition has to fit into a very certain box to qualify for hospice. They have to have a very specific set of symptoms to meet criteria for hospice. And sometimes this can be really tricky, even if a person has a lot of decline, it may not be what the eligibility requirements say. A second barrier that we see is communication challenges, and this is usually between the physician and the patient. And sometimes, quite often really, the physicians are unsure how to have that conversation with patients. And sometimes they don't know how to communicate that a patient's prognosis and really treatment options are limited or non-existent without stealing that person's hope or robbing that person of their hope. And so sometimes what we see is that physicians are really unclear when they're communicating this, or sometimes they prolong or procrastinate, I guess, in having this conversation with patients because they don't know how to do it effectively and they feel very uneasy about it. A third barrier is that sometimes a patient and family's optimistic goals of treatment, and that really prevents them from accessing hospice until the patient reaches a medical position that it's become very clear that they are dying and that they don't really have any other options. Sometimes a physician is fantastic at communicating what's going on, but their life expectancy is uncertain. The physician can't say for sure how long a patient has to live. And in order to qualify for hospice, a physician has to determine that a patient has 6 months or less to live. And if anything, doctors are more conservative on this, and they will estimate a longer period of time than a patient actually has, mostly just because they really don't know. They really don't know, and it's hard to say for certain how long a patient has. And the fifth barrier that we found is there's racial disparities in medical services across the board, but it does filter into hospice, and we'll look into this a little bit more. But first, so who does use hospice? And primarily the population that uses hospice are white individuals, and they're economically stable, they're financially stable. There's more women than men. And as far as age goes, only a third of hospice beneficiaries are over 85. So that just kind of gives us a view of who does use hospice. In 2013, according to the National Hospice and Palliative Care Organization, the percentages of hospice beneficiaries were as follows. So you can see here that, again, primarily white individuals are accessing hospice. And even if you look at the other races here, you'll see that their percentages are very low. It's a very low number. And so why are we seeing that? And given here are just three of the possible explanations. The first is that minorities and low socioeconomic persons may not have health insurance. And when you don't have health insurance, you're not seeing your doctor on a regular basis. You most likely don't even have a primary care physician. So if you're not seeing a doctor regularly, you are not getting an early diagnosis, and therefore you're not getting a hospice referral. And really what we see is that minorities and low socioeconomic persons are dying in the hospital rather than on hospice. And studies have also shown that there can be a lack of diversity on hospice teams, and this can be a deterrent to persons who feel that an all-white hospice team isn't going to understand their situation. And sometimes hospice outreach efforts have targeted a really narrow population, and that you can see that in the pictures that I have included in the slide below. There's 4 different ads here. They're all from different hospices across the U.S., and they all feature white patients, and all of them appear to be very clean, very, very well-to-do. They're very admirable people. And you really see that as a reflection of the patients who are actually utilizing hospice. So it'd be interesting to see what would happen if the outreach efforts targeted a wider population. So what does a hospice social worker do? Hospice is not the same across the United States. There's different types of hospices. There is nonprofit versus for-profit hospices. And those two different types of hospices have a different set of regulations. So really what that means is that each hospice has a really unique dynamic to their team. And it's not the same across the board. So it's hard to determine that exactly, but one thing that a hospice social worker will do, no matter where, is they'll be working on an interdisciplinary team. And that means they're going to be working with doctors, they're going to be working with nurses, chaplains, volunteers, the hospice director, CNAs. So you're really working on a whole team to meet the needs of the patient. A hospice social worker will complete an initial psychosocial assessment with the patient upon admit. And what this assessment does is it kind of provides a baseline for the social worker and kind of tells the social worker what the patient, who the patient is and what they want to accomplish before they die. It assesses things about, is the patient suicidal? Are they anxious? How are they doing with this new diagnosis? What do they want to accomplish before they die? And so a hospice social worker will meet with a patient and family at least every 14 days, if not more often. And sometimes what they'll do in that time is complete other assessments, such as the mini mental status exam, which will monitor cognitive decline, or a geriatric depression screening, or even a SWOT, which was designed by the National Hospice and Palliative Care Organization, and it emphasizes the patient's quality of life. So it's just really reiterating what hospice's goal is and making sure the patient is, it has things the way that they want. All of those things help the social worker design a plan of care for that patient based on what they want. Social worker can also be a mediator and facilitator for the patient if there's something that they want to see happen before they die, or if they want to have a hard conversation with someone that they've been at odds with for years. So that's something that a social worker will do quite often, as well as advocacy. Advocacy is also huge for hospice social workers, especially because you're working on a short time frame. Sometimes this can be a pretty big part of it, is you're really wanting to advocate for that patient and get them access to things that they need to see happen before they die. And probably the hugest task of a hospice social worker, and probably social workers in general, is communication. But in hospice social work, that involves medical charting and speaking with that interdisciplinary team, the nurses, the doctors, the CNAs, all of those people about the patient's needs and plan of care and what that should look like. Cicely Saunders was the founder of hospice in the United States, and she said this about hospice's goal. She said, "You matter because you care. You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." Hospice really is all about life. It focuses on allowing people to live as comfortably as they possibly can, and it focuses on meeting the needs and helping people go through that process and see the things happen that they need to see happen. If we look at the beginning of this presentation, we describe the elderly and the dying as being forgotten, undervalued, and underserved. We can really recognize the great need for social workers to work with this population, not just in hospice, but in other capacities as well. As social workers, we seek to help those who are discriminated against, and the elderly population is very much discriminated against. Hospice is one way that we can change the dying experience for the elderly.